Okay, so we will be making this recording available to people, whether they attended here or not. So just be aware of that. And I, given my own experience with 988, am really excited about this event and excited about the number of people who are joining us. We have nearly 400 people who registered. There was a little rush right at the end there. And if we didn't already know that 988 was big on people's minds, this registration has certainly told us. If you are not aware with the history, you're going to get a lot of history from others, but I will just say 988 was introduced in July of 2022. It became an official thing. And now we are about a year and a half later. So that seems like enough time to stop, pause, and say, like, all right, how's it going? 988 is funded, if you're not aware, by the Substance Abuse and Mental Health Services Administration, and it is administered, so to speak, by Vibrant Health. And I actually can think back to a time not that long ago when I was listening to Vibrant Health say how great everything was going at a big conference. And even then I had some questions about that, if that was actually an accurate or a full portrayal. And we're going to hear a lot about that today. Now, like, is that the full picture? What are we actually seeing? But if you aren't aware, there was actually also an article that came out in October based on some research done by the Journal of American Medical Association that CNN published. And some of that also started to tell us, oh, there's another story. There's a bigger picture here that maybe that initial report from Vibrant Health was missing. The report, I'm not going to get into that article in depth, but some of what CNN was saying was only a quarter of people that they surveyed were likely to reach out to 988. And of the people who had reached out to 988, only a third of them were likely to reach out again. So that suggests a bigger story for us to look at. So today we're going to be talking about this from a number of angles. We're going to be talking about it from the angle of someone who has worked in those crisis systems and continues to consult to them nationally. We're going to be talking about it from the angle of a journalist who, as far as we know, is really one of the only people who's digging into what the data is truly saying about the use of force and police involvement in 988, and we're going to be talking about it from the perspective of a mental health advocate who has personal experience calling 988 on multiple occasions. I'm really looking forward to hearing what they have to say. And just to let you know, the overall format of what to expect here is we're going to turn it over to them to each share some, and then I'm going to ask them a few questions, and then we're going to turn it over to you to ask questions as well. And our moderators, Earl and Sasha, are going to be giving you a link in the chat where you can submit some questions. If we don't get to all the questions, which depending on how many of the nearly 400 people end up here today, we probably won't, we are committed to doing an additional recorded session where we won't have a live audience, but we'll go through some of the questions that we missed and we'll offer some answers, and we'll then distribute that and share that out as well. So if your question doesn't get answered here, know that it is not lost. And when I send out something probably tomorrow, also sharing some of the resources we talked about and the data we talked about, you'll also have another opportunity to just let us know, oh, is there any question that we really missed that you'd like us to address in that additional session? So thank you to Sasha and Earl for handling the chat and sharing all that information with you. Thank you to all of you for being here today. And at this point, we are going to begin by turning it over to Jess Stolman-Rainey. Now, Jess, I've known Jess and appreciated Jess's work since I knew her back at Rocky Mountain Partners in Crisis. I might not be getting that name quite right, but you will correct me. So that is when I first met Jess, doing that work of overseeing both a crisis and a peer support line in Colorado. And I've so appreciated her voice in all this. And she is such expertise on what it's looking like, how it got kind of started from the inside and what it's looking like now. So Jess, I'm gonna spotlight you and then it is all yours.
All right. Um, Thank you. I know I had some internet issues like right before we started, so hopefully everything is going okay now. Sorry if I get a little bit weird sounding or something. I I have done lots of work within these systems, and I think that there are lots of ways that these systems can be both helpful and harmful. I think there's a really a mix of how that shows up for individuals' experience when they call these lines. But I wanted to talk a bit about how these crisis systems have evolved. I'm going to do a like really boiled down version of some history. So, if you work in these systems and you think I'm missing something, I probably am. I'm leaving quite a bit out. I'm trying to hit some highlights, and we might all pick different highlights about what we think is most important in that history. But hotlines that evolved into what is currently 988 really started with lost survivors who felt like their lost loved ones really needed someone to talk to. They've become sort of increasingly more monitored and supported by the government, which has both like benefits and drawbacks, I think. And we can always talk more about that later if that's helpful for folks. The Lifeline, which is now 988, has always been a network of centers that provide services. And so I think it's important to know that it's a network, it's not one organization. When you get when your phone call is picked up, it's going to be lots of different people who might be picking that up from lots of places. There are backup centers and things like that. Um, so the big thing that I think happened with 988 is that it designated the suicide prevention lifeline, that's what it was previously called, as a national mental health crisis line. And what that means is that it has become compulsory for your state to participate in the network and that they have to provide the service. So previously it was just centers chose to do that, or they did it by contract for the crisis system in their state. I know that's kind of complicated, but this was a big shift in the way that this service was provided, is because it required states to participate. So 988 is the new phone number that you would call. It was a longer phone number before. It really, I think really advocacy around that change followed the way that 911 was developed. I'm not going to get super deep into that history, but you can look some of that up if it's of interest to you. So states are responsible for delivering the service. The network is really expanding their service to apply to all crisis and not having as much of a focus on suicide, although suicide is very, very clearly a priority in the conversation. And we'll get to some of that later. The National Suicide Hotline Designation Act is the act that required the FCC to designate the phone number. So that's how this legislation worked. So the Federal Communications Commission, that's the same people that give you a TV or a movie rating and stuff. That organization is also overseeing this. That designated the hotline. So that meant that all of the phone systems that exist, so like T-Mobile, all of those places had to make 988 route to the Lifeline. That's what that act meant. It was the universal telephone number for a national suicide prevention and mental health crisis line. Vibrant Emotional Health won the SAMHSA grant, so the Substance Abuse and Mental Health Services Administration grant, to be the administrator. So that's the nonprofit that does the administration of 988. And then underneath that nonprofit are all the different centers that operate the network. And those are decided typically by contract with the state that you are in. So your state has a tremendous amount of control over what the provision of that service looks like. Since the states have to administer it, the act gave them the ability to do things like collect a fee for providing services. Lots of different ways. There's lots of different ways of funding 988. Depending on what state you are in, it is better or worse funded. Funding makes a huge difference in the kind of caller experience that people are going to have. So I think that's important to note. Your state is also then responsible for creating the contract that decides how the administration of this service is going to work, including things like what training is required for your hotline workers in your state, what kind of standard they have to have for their professional background, or if they have to have one. That there might be information about whether they're going to be volunteer or paid staff, if they're going to have a clinical background or not. All of that stuff is really determined by your state. And so that's how that works. The Department of Health and Human Services and the Department of Veteran Affairs are going to be doing reporting on operationalizing 988. They developed strategy for how to access the service. They also created some specialized groups or designated some specialized groups that you're supposed to have some training around, or that might get specific services. So that could look like LGBT services, that could look like services for rural people living in rural areas, things like that. They designated populations that are considered high risk. Later, text to 988 was approved, and in the original kinds of documents that came out, peer support was listed as one of the services that people should be able to access. Well, the thing about that is that there wasn't actually a plan for peer support to be accessed independently. It's really something that there isn't a lot of guidance around how peer support is going to operate within these systems. So there's lots of big question marks there, and there's lots of barriers to people being able to directly access peer support. So what people are really getting is a clinical approach to mental health and suicide support through this line. So what that means is there's a clinical screening or assessment that's required by counselors. So when this system is properly resourced, it is supposed to connect a person in mental health crisis to a trained counselor, reduce healthcare spending, and that's by diverting people from emergency services and ideally providing what they call cost-effective early intervention. The availability of those early intervention services, I'm going to put that in quotes, early intervention services, they get defined differently in lots of places, but the availability is going to depend a lot on what your state actually has for people to access. It is supposed to reduce the use of law enforcement, public health, and other safety resources, meet the need for the growing need for crisis intervention, and in theory, and help end stigma to people who are accessing crisis care. I'm not sure if that one is really a practical goal for a service being provided, but that's part of what they said. So every state is resourcing this really differently. There are backup centers that pick up calls. And then there's text and chat, and crisis text line is the backup center for text and chat, or has one of the contracts for it. That's something that I think is a complicated space. That crisis text line is that provider. If you want to do some Googling, you can find out more about why. But the people who are providing the service then might not actually be from your state if you're going to a backup center. So this is where things get really complicated. Each center trains their staff differently. The more training and experience the person has, the less likely they are to be coercive or carceral in their interventions if they hold values against that themselves, which they may or may not. So not everyone has those values against forced treatment or coercion, like those of us on this panel holds. And so even fewer people actually know how to act within those values when a situation feels really unsafe to them. So ideally, this system is supposed to use the least restrictive intervention, but I don't think it operates in an ideal way. And it never actually has, in my experience working with centers. So ideally, a system like this could help us move toward a less coercive or carceral response, but it isn't actually designed that way. There's not good evidence that either suicide assessment or forced hospitalization are reliable ways to predict or prevent suicide. So it's complicated that the system really hinges on those two things, because it does. It requires a suicide assessment for anyone who is talking about suicide on these lines. It's pretty common for people to get involved in suicide prevention because they're loss survivors. Oftentimes it means that they're really willing to prevent suicide at all costs. I think that's a mentality that can often lead to carceral logics about intervention, like active rescue or emergency rescue. So which really looks like 911 or welfare checks and geolocation, things like that. When I say carceral logics, I'm referring to all the different ways that our bodies, minds, and actions are shaped by the idea that practices of an imprisonment are helpful in mental health, quote unquote, support. So this a 911 intervention that is connected to 988 could include or could expose people to risks like dying, jail, or long-term hospitalization, forced hospitalization. It takes the perspective that people in crisis can't make decisions for themselves. That's sort of embedded in the system, which is really complicated. Um, and is hard to work against if you're an individual provider. Geolocation is also a sort of a hot topic here. I wanted to address that really briefly. Geolocation is, I just want to say this first, geolocation is always already a coercive intervention. It assumes this idea that we should be able to find someone without them giving us their location. Um, Tracking people's location without consent assumes that the service will send emergency services without your consent. I think it puts us on the wrong side of history for doing this work. Crisis services can do better than that. I think it's a bold claim to say that we really care about reducing the use of law enforcement, public health, and other emergency resources or safety resources if we were going to already build in geolocation services. It really pushes us as a system toward using things like non-consensual welfare checks, referrals to services that use involuntary treatment without discussing the treatment that's used, all of that kind of stuff. Um, so that's some of the complications. Geolocation can show up in a few different ways. Currently, calls are routed by your area code. There are also ways that you can do routing by a tower that your cell phone pings off. That might be more useful potentially, depending on how you think about this, right? Is getting access to resources in your actual area might feel really useful to people. And then there's exact location, like finding your exact location using geolocation. Right now, there's the sort of movement toward doing a feasibility to study to look at what it would look like to implement geolocation. It's extraordinarily expensive. Some people some 911 PSAPs, so 911 providers already use geolocation. Some of them don't think it's ethical. Some of them don't think it's legal. So it's a really complicated space to look at that. So geolocation is a complicated thing. It's not currently happening as a part of the 988 system in the way that some folks might think it is. But oftentimes people are asked by a call center or call taker to provide their address as part of their introduction to the service. You probably have your address online somewhere. I would bet you do some Googling. There are ways you can get your address off the internet. I'll give you some resources for that in the chat in a little bit here. But a call taker can Google you to try and find you. 911 can try and Google you to try and find you. So there are lots of ways that people might send law enforcement to your home if you're using this service that don't necessarily have to do with geolocation, but it can feel like geolocation. It takes the same approach, right? That same carceral logic is showing up there. So the last thing I wanted to talk about in my few minutes I have here, I know I'm kind of jumping around and going to a bunch of different things, but I wanted to talk about what the impact of implementing this new system is on the providers who are originally doing this work. So there have been call centers that have been doing this work. I think lots of them are doing it really well. Lots of them have room for growth. Like there's a lot of difference in the types of contact centers that are doing this work already. The smaller your organization is that's providing crisis services, the harder it is to stay in this 988 network over time, because all of the big organizations that are part of the crisis industry, this is an industry, all of those big organizations really, I think, saw dollar signs in this process as they see access to resources that didn't previously exist and are really sort of picking up the service in a lot of states. So as states are putting out requests for proposals for organizations to answer these calls, these calls are then being handled by these big organizations that can do it for less money, that maybe have access to better technology and things like that. So the service is becoming less local. It's becoming less grassroots. It is less likely that peer support can be available. And it's less likely that organizations with more liberatory approaches to crisis are going to be picking up the phones. So So these smaller community centers, some of the things I foresee happening are that some of these smaller centers that have been operating for a long time in their communities, maybe in ways that were extremely beneficial to their communities and that they felt the communities felt really empowered by, are losing funding because the state is streamlining all of these services toward 988. So even things that maybe previously existed in your state might be getting pulled as from funding streams for those other services to exist in favor of 988 being this centralized place that everyone calls for mental health, substance use, suicide prevention, support. So there are big financial issues coming, and I foresee a lot of these smaller community-based centers that maybe are providing more liberatory approaches, really struggling to find the funding to do the work that they want to do, that their communities maybe were participating in the development of, in ways that that 988 didn't really allow the communities to participate in the development of the current service. All right, Sarah, am I on time? Do I have a couple more minutes?
If you want to take like 1 or 2 more minutes, but we're right on there.
No, I think I'm right on time. I'll stop there. I was gonna address some later stuff, but I'm good.
All right, thanks so much, Jess. I really appreciate how much knowledge you're carrying around about how these systems are working. So we are next going to be hearing from Emily, and I'm just going to spotlight Emily. So I've also known Emily for a while, but not as well. I've known Emily as a mental health advocate. Emily's been on my Facebook page for a long time, clearly has lots of creative and artistic energy that she brings with her. And then we really started to get to know each other more directly when we both had some experiences with 988. So I will say that and turn it over to you.
Awesome. Thank you so much for having me. You know, okay, so in a nutshell, like the reason why I'm on this panel, and I'm honored to be on this panel with all of you, reconnecting with Jess, because I used to be on a fellowship with her in San Francisco. It was like a change agent, Each Mind Matters, and we were both given scholarships to attend the Together Against Stigma conference in San Francisco. And Eduardo Vega was in charge of that program. And then like, a couple of years later, then I get, I remember, I believe that you and I, Sarah, were connected through the Alternatives Peer Conference. And where others, I met psychiatric survivors there, but I myself was never 5150. In the last 10 years that I've been an advocate for the, underserved, inappropriately served, immigrant communities from Asian descent. And so, and I've actually been feeling like a minority of minorities, in my own community, because they think I'm so different, I'm so outspoken. I'm not your typical model minority Asian. And when I used to be, and so I just felt like, when I get inspired by other advocates that say, like, if not who, if not me, who, if not now, when. And so I'm kind of like the out of the box thinker. People call me a free spirit, and and so I like to challenge the system and ask them, why do you do it this way? Why do you do it that way? And it's like always asking why. Why are things the way they are? And so ever since I got 5150 because of 988, which I have vowed to never, ever, 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 ever call again, I'm like, my life has turned upside down. And I'm just like, wow, is life a joke? Like the systems that humans have created for so many years. And it's like, why did 988 choose to create a pilot that just went out to the whole country? I'm like, why did you test it out first and then roll it out instead of making it official to the whole entire country? And so that's one of the reasons why I was like, okay, for me, I'm kind of like, when I promote, if I promote a number, warm light, I want to be able to know what it's like to call them myself. And which is why you know, as a person who has, you know, been a mental health advocate for the last 10 years, was involved with NAMI, um, doing support groups and classes, peer-to-peer, but never a super fan of psychiatric drugs, but still respecting other people who take them, because to each their own. Everyone has to figure out their own cocktail. And so being 5150 for the first time, I was just like, what? Wait, this is what happens? And to move backwards, it happened on July 29th. I called 988 in a moment of shock. And I I needed someone to process my emotions with, close to the middle of the night. And I, emotionally I felt alone, and my normal wise mind coping skills was not coming out in that moment. And so I was crying, and I did have suicidal thoughts. I admit I had suicidal thoughts, but I did not have a plan. Although I can understand how the first responders would have thought I had a plan, because I was on the phone with 988 in Sacramento, even though I am Los Angeles based. My call got directed to Sacramento. And I researched that the Sacramento Crisis Call Center was WellSpace Health. It didn't get routed to Didi Hirsch in Los Angeles. And so after being on the phone call for 90 minutes with a guy named Mark, I believe, I'm shaking as I retell this story, but it's healing for me to tell my story, because the more I tell it, the more I heal and accept. Kind of like being a survivor, the more you tell the story over and over and over, the more you try to heal. And that's why I am sharing my story here. And so after the 90 minutes, I felt like he gave up, and he said, pass the phone to the security guard that you see. Yes, I was on the top floor of a parking garage, but I have been to that parking garage before, and nobody bothered me and my friend. I was there with my friend when she pulled the suicide word on me. And so I felt obligated as a friend to be there for her until 3 a.m. in the morning, when I was so exhausted and tired. No security guard came out last 2 Octobers ago to express any concerns, even though we were on the top floor of the parking garage next to the mall. And so this time around, this past July, when I was in the same space, I never even touched the ledge. I was just crying profusely. And so after I give my smartphone to the security guard, I like, that is my biggest regret, ever passing my smartphone to the security guard, who then called 911 on me. And then all the first responders, all male, showed up. So not to put a stereotype on males, but I mean, like, I understand, like, first responders' jobs are, oh, just get in there, you know, hurry up, make a hurried decision, you know. And I mean, like, the way in California, it's called a 5150, a psychiatric detention. And so the way that the Arcadia Police Department, the wording they used to inform me that I was being 5150 was, at the entrance of the ER at USC Arcadia Hospital, they said, I'm sorry to have to do this to you, but do you know you're being 5150'd? I'm like, what? And I'm thinking that in my mind. What? So I, and immediately I also thought about my friend's younger sister in July 2012. She wanted to escape a 5150 and the cops killed her for it. Just Jasmine Ha Eng was her name. And so even one of my extended relatives, he also, one of my distant uncles, he went to the ER and he was 5150 by the ER and the social worker in the ER. And they didn't tell the family that they were hospitalizing him at Aurora Las Encinas Hospital, and he died the next day. And I assume it's from psychiatric drug overdose. So this is, like realizing how terrible 5150s are, I'm just like, oh my gosh, why didn't the system show up for me that night? Where was the psychiatric mobile crisis team? I've even talked to the mayor of my city to ask to have a meeting with the Arcadia police captain and the Arcadia fire chief. And even when and this is the bizarrest thing, after I got 5150 and got out in 50 hours instead of 72, I got a bill. I got bills amounting up to over $3,300. I'm like, what the hell? If the law can legally kidnap people against their will and chuck them to the hospital without their consent, surprise them, and not be able to legally leave in a calm way, because I wanted to just walk home. I'm like, what the hell? This is happening to me. And then the resident doctor, she was like, oh, the only way you're going to get out of here is if you give us consent to draw your blood. And after that, like, nobody showed me what my patient's rights were. No one at USC Arcadia Hospital ER to this day, even though I have submitted multiple grievances to both USC Arcadia Hospital under Keck School of Medicine and Kaiser Mental Health, Kaiser Permanente, their psychiatric ward was like, oh my gosh, wait, am I in the sequel of One Flew Over the Cuckoo's Nest? Where's Jack Nicholson? I need to report to Jack Nicholson what I'm experiencing. I'm like, oh, this is what they think is healing? Fuck that. Sorry, excuse my French. Oh my God. I'm like, I've had a conversation with Rob and I told him, I'm like, oh, I'm gonna make a plan out of this because this is so absurd. Life is a joke. And that's why I laugh, because when the system thinks that they're, oh, like they have this savior complex. Why? Why do you need to have this savior complex to prevent someone from, you think that putting them in isolation and seclusion, taking away their phone without telling them why is okay in the ER, and to throw away their food when they're not even ready to, they're not finished with it yet. That's what the nurse did to me. She's like, oh, are you ready? Are you done with your breakfast? Oh, wait, throw away. She didn't even wait for my response. And she did that right in front of my husband when he was visiting me. He visited me 3 times. He visited me multiple times in my 5150, in my 50 hours. And I call it, you know what? I call it anything that is done to you without your consent is like rape. So I really feel like I got raped by the system. And I feel like it's extreme betrayal because I used to be the face. I used to be the face of the California mental health movement called Each Mind Matters when it used to be called that. And now it's just called take action for mental health. I'm like, not everyone is ready to take action yet. In our East Asian communities, NHPI, Asian American, Native Hawaiian, Pacific Islander communities, there's still so much stigma. And if anyone from our community was to find out how terribly I was treated in the psychiatric ward and the ER, they would steer clear away from mental health. Oh no, I have no problem. That's for nutty people. That's not for us. If we, why should I be paying for mistreatment? How does that make any sense? So knowing what I know now, I'm just like, now I have to, it's like I have to put out like these warning signs of like, don't call 988. What happened to me could happen to you. So find other ways, find other warm lines. Go talk to your local people. Because I've been facilitating support groups since 2016. I know what safe spaces look like. Because lots of people turn to me and come to my support group because they love the safe space that I make them feel. That you're not judged. That you are accepted here. Heavy emotions and all. Let yourself speak your mind. Say what's heavy on your heart. It's not my therapy session, but many people turn to me because they know that I'm a safe space. I am a safe resource. And so now that I know that 988 is a emotionally violent resource, I'm like, no, never again. Never
Emily,
again.
thanks so much for sharing so much of this. Can you wrap up in the next minute?
Yeah. So anyways, I guess I could end there. I'm just really grateful to be here with you, Sarah, Rob, and Jess, and every one of you here. Like over 183 of you. So thank you.
Thank you so much, Emily. I know that is a lot to share, and I appreciate when I've been able to hear and be in the space with you when you have shared. Really appreciate it. We are going to move on to our final panelist now, who is Rob Wypon. I am just looking for you in my scrolling list here.
I am here somewhere.
Yep, I found you. There you are. You're spotlighted
Right.
now. So
Yeah.
Rob is another person I can say I have known for years and in very, different ways. Each Jess, Emily, and Rob, I've appreciated so much of your work and that you were one of the only people, if not the only, doing it. You were my favorite NARPA keynoter that I can recall. NARPA is a National Association for Rights Protection and Advocacy Conference. Rob and I were both there a couple of years ago, and I heard you speak about your book. So I look forward to hearing you today. Thank you.
Thanks a lot, Sarah, and thank you, Emily and Jess. I want to say, like, that's how I got interested in these issues with the National Suicide Prevention Lifeline, now 988, from talking with people like Emily who went through these frightening and devastating experiences, often the sense of betrayal alone, that your confidentiality has been breached in this way, and that your call or your location was somehow found, and you ended up at a psychiatric hospital. The betrayal alone can be devastating for people, let alone all the other facets of it, some of which Emily was just touching on, the police intervention itself, maybe they're strapped down in an ambulance, they're taken at the hospital, they could be subjected to restraints, evaluations, all sorts of things that people can also find really painful to go through. And we know that the suicide rates after psychiatric hospitalization go up exponentially. Every study that's looked at this question has found that. So we don't know that this is in any way a helpful intervention. And so that's what got me interested in it. And one of the reasons that everybody should be concerned about whether or not 988 is helping or harming and how much of each it's doing is because if you go to the National Association of State Mental Health Program Directors website, these are the association representing the people who actually run state mental health systems. You'll see lots of reports and feasibility studies and analyses where they're looking at essentially positioning 988 moving ahead as potentially the heart of the entire mental health system. So they're sort of envisioning a world where anyone seeking any kind of mental health assistance would go through 988 and then kind of be referred somewhere else, a kind of, spoke in the wheel or something. And so that vision, I mean, obviously that's in the future, but that's kind of where they're investing their money, their thinking. And so everybody should be concerned about that because there's lots of questions that emerge then if this is essentially a kind of like an operational mental health care system working through 988. So what I'd like to do today is just kind of delve into a few things that get talked about a lot, and there can be some confusion out there. My fellow journalists are often the worst at this for obfuscating the issue, and it's being deliberately obfuscated, I find, by Vibrant Emotional Health and by the 988 administrators, where you can't really get an accurate read on, well, what kind of tracking is done, what are the standards in place, what are the policies, and it's just very eloquently elaborated upon. One of the problems here is this is an affiliated system of people with very different policies and practices. So you don't really know what's going to happen when you call 988. And that's part of the problem. You don't know what kind of call attendant is going to answer and what their values are going to be and what their training is. And you also don't know technically what their capacity is going to be for intervening in some way. But we do have some stuff to work with, and I want to kind of delve into it today. And I have some slides that'll kind of help us talk about it. So I'm going to share my screen for a few minutes and we'll walk through them together. So I'm sharing now and from the beginning. All right. Am I there? So that's just my book, Your Consent is Not Required, where I look at the rise of these kinds of involuntary interventions. As to be clear, this is my problem with 988. I recognize that lots of people get value from calling and talking to somebody for a little while. My concern is interventions that are done without consent. And that's what my whole book's about. And there's a chapter there specifically on 988. Now, this is the National Emergency Number Association interoperability standard between 911 and 988. And this is relevant because, yes, 988 currently does not do geolocation in the electronic sense. They don't have the technical capacity to track, but 911 does. And so there's an agreement now between 988 and 911 about how to do this kind of tracking and how to do interventions. And so I'm just going to walk through a few of the relevant things here. So they have this standard around imminent risk. A lot of people know that. So essentially, it's not only, and in fact, it doesn't even seem to be the majority of people who are actually actively in an active suicide that get subjected to this. Rather, it's people who the call attendant thinks they might, in the relatively near future, potentially take their life in some way. And that can create anxiety for the call attendant, and they'll implement the rest of the policy we're going to walk through here. So this is the PSAP is the public safety answering point. Every locale has one of these, usually more than one, but essentially it's the people that oversee 911 and or the police or somehow both. It's a designated response area. And these people have the capacity to ping basically any kind of mobile electronic device that might be contacting them directly. This was created as a standard to allow them to save people who might be calling for help through 911, which is great. But now that it's implemented in these kinds of circumstances and in other types of circumstances, it raises a lot of questions around it. So here are some of the practical ways this can be done. The crisis line may share the following information with the PSAP, which would include your location, if they already know it, your caller ID, your internet protocol address, if you're using chat services, And this will all lead to activating emergency services and being transported to a facility for further care. And I want to note there at the bottom, there's an incident or event number that they're trying to get, hopefully in this kind of case, so that they could potentially follow up later to make sure that all of this in fact did occur, that you did get taken to the hospital. So these procedures now, here's where they highlight how it's kind of done. So you look at the first one. This is sort of a recommendation of the PSAP. This is what we would like you to do. So they may or may not actually implement any or all of this. But the first one there in the list is request that a carrier ping your location. So that's the most effective way to do this now. It's instantaneous. You have to get the carrier of the person to actually do it for you, though. Like the police are basically kind of like getting a search warrant, except they don't have to use a warrant in this case. They just ask, they make the request to the carrier to ping your location. Other means they may use, because that may or may not work. There could be a million reasons why it may not work. It may not be fast. There may not be agreement in place. You may be out of a service area in some way at that time. So they'll also appeal to subscriber information, your name and address there, any alternate phone numbers you have. They may search any call records that you already have with local police or with the PSAP. They'll, at the bottom, you see they also may do social media searches. This is what Jess was talking about. So any and all of these kind of procedures can come into play as they try to find you. And they just note here that, yes, even being on the internet, they can get a 90% success rate with that. So yeah, these are pretty effective, but not universal. So what are the current numbers? Well, there's been 8.1 million calls. The most recent information I got from Private Emotion Health and SAMHSA was about 2% of these are getting subjected to the kind of interventions we're talking about, although there's a mix there of both with consent and without consent, and I'll return to that in a moment. So if that's 2%, that would be 162,000 people since July of 2022 have been subjected to this. And that does not include, that's a police ambulance intervention, that does not include mobile crisis team interventions. And it's important to understand that they may also ultimately incarcerate you. It's obviously better. They're usually not armed. There is not a police officer with them. So you're less likely to be shot or something like that. That's great. But you're not really all that less likely to be locked up in a psychiatric hospital when you get a mobile crisis team. I just want to give a quick shout out to Tim Ryerson here. He's the whistleblower that about Crisis Text Line, revealing that they were recording data and sharing it with their own for-profit arms, selling people's call texts exchanges with them. And he highlighted for me some of this data that I'm now going to show you, which was available from the New Mexico crisis line, which is showing quite great data. And I just want to highlight here, I went looking for the privacy policy today at the 988 site. There's really nothing. It's embarrassing. If you work for 988 and you're on this call, you should be embarrassed. You should be ashamed. This is staggeringly unprofessional. They have really no meaningful privacy policy per se. The privacy policy about their website is great. It's fine. They have nothing about callers. Even their texting one is minimal at best. It's just is shocking. Like I can't believe I spent 20 minutes trying to find something better. I could not. If there is something better, please post it in the chat. So now we'll look at some of the numbers here. So this is from New Mexico. You'll see they get about 15,000 calls a month. So I'd call that a small to mid-sized call center. And so here's the average call length, about 20 minutes, but this is for the highest level of care. So that's what they're calling their clinical calls, where a complex call. So the average for most people is actually going to be lower than that. So again, you kind of wonder, how well can you really assess somebody in that kind of time frame? Now, this is what I really want to draw your attention to, and we're going to come back to. So here are the reasons for the calls. You'll see at the top, suicide is about 27% of calls. This is highly relevant to understanding the data. So people call these lines most people call these lines for totally different reasons. And you'll see there, situational stress, substance use, family concerns, grief, loss, medication concerns, trauma, sexual assault, experience of that. So these are just other things that people want to talk with someone about. So the vast majority, and this is highly relevant then to understanding what's really going on with these lines. So here's a nice section called disposition at the end of the call. So this is relative to all of those calls. And we can walk through. So we see that 90% say that basically the call ended okay, and the person may have been referred to a community resource that was available. Then going down from there, we see the other 10% is that an abuse report was made. That would be a mandated report, I would guess. So police would come. The caller took the person to the hospital. So this is when a third party calls. I'm worried about so-and-so. So that person then takes them to the hospital. The caller themselves agreed to go, or they agreed to call 911 themselves. I want to highlight that because the next one is call their conference to 911 due to immediate danger. So that's an interesting phrase. So what they actually seem to be doing here is connecting themselves and the caller directly with 911. Now, is that with consent? I would say probably not, because in the previous number, that's where the person agreed to call 911 themselves. So they're connecting you to 911 and exposing you now to a potential tracking experience. And then they actually highlight down here at the bottom, counselor contacted police with caller consent, or counselor contacted police without caller's consent. And if you look at those numbers, they're all, the ones at the bottom, they're all around 3, 1.6%, 2%. And that's roughly the publicly stated rate that we hear of these kinds of interventions. And what does with caller consent really mean? I was talking with Jess about this, and she highlighted for me what other people have told me is that can really vary. Often it could just be, if you don't agree, we're going to call 911 on you. So you have to agree. So it can be very coercive as well. So now I want to look at this, which is great that they do this. I credit the New Mexico line for their data here. So they have disposition for only the suicidal callers. And now we see something much different. 20% of those are not being stabilized or referred to community resources. We'll look at all these other situations. That means 20% are getting some kind of intervention that's probably coercive, highly coercive. And you can see down, just even if you just look at the one at the bottom, counselor contacted police without caller's consent. That's 5%. So we're already double to triple the officially publicly stated rate of interventions. So essentially, Vibrant Emotional Health and the 988 administrators are hiding the true rate of these kinds of interventions by disguising them under the 90% of calls that are about totally different things that have nothing to do with immediate danger or suicide. And the true rate is closer to between 5 and 20%. So you can imagine now, if you're a person with suicidal feelings and you contact 988, this is really saying to you, you've got about a 1 in 5 chance of having some sort of police intervention with or without your consent. And that's what I think is really important to understand. So that's my book. And yeah, I'll just stop sharing now. So yeah, that's what I wanted to highlight. This, as you can see, I kind of get upset about it. I think we need way more transparency with the numbers, with the policies. We need much more professionalism. Like, that's what I call this. This is a stunning lack of responsibility and professionalism on the part of the 988 administrators, that they're not being more forthcoming about this, that they don't have clear policies in place, and as to what these procedures are really going to be, so that you have some idea. And I really think they should, when you call or text, right away say, have you ever contacted us before? Are you aware of our policies? And direct you to read these policies that don't exist. Hopefully they will exist, so that you understand what the risks are about what you could say that might get you into that kind of trouble. With that kind of transparency, I think we'd be better off, although I'm not sure, based on their behavior, whether I'd really trust them to implement such a thing really well. So that's kind of the summary of my talk, but I saw some great questions that came in, and I'm excited to chat with all of you about some of the questions.
Thanks, Rob. Yeah, and we're getting a lot of questions on our forum that I know Earl and Sasha have been putting the link out to as well. So just a reminder to people, we're going to ask a few questions to our panelists that we have already had in mind, and then we're going to go to some of your questions. I can see by the number of questions we have in the forum, we're not going to get to all of them, but we are, for those of you who didn't hear me say this earlier, we are going to then follow up with another recorded session without a live audience and answer questions that got missed, and then send that out as well. So our first question, much of what we've been talking about here is about support that's offered that could potentially lead to force. And I wonder if any of you could also talk about what about some of the other things that come up? How are they doing? Do we know how they're doing or what sort of support they offer when force or whether or not to call the police or emergency services of some sort isn't involved? What are the other kinds of concerns that are coming up? I don't know, Jess, Emily, if you or Rob, if any of you want to jump in here.
I think I have a couple of things related to that to say. So one of the things that comes up for me is that because the ramp up toward this service was so fast, we're really not the people providing this service are often not people who are like career crisis workers or people who have done this a long time. So their sort of tolerance, their threshold for being with risk is really, really low. And the focus of almost all of the training is about assessing risk and not about how to support the person. And so many places, they don't actually, like, people don't actually know what to do if someone isn't suicidal. They don't know how to support a person who isn't suicidal. And really, they don't know what to do if they're not doing a risk assessment, basically. And a risk assessment isn't actually support. And some of the way that this gets framed in trainings in a lot of places is that the risk assessment itself and the safety plan is the support. And I don't think that's actually accurate, sort of based on my experience. So I think that's really important to consider, is that people don't actually know what they're doing. They struggle the most with calls where people aren't suicidal, and that's most of the calls that people are getting. I think, especially when callers are engaging in self-injury, that is the space where I think like crisis, the field has the most to learn. And oftentimes people are extremely shaming. They don't use harm reduction practices. They treat that like imminent risk situations and send law enforcement, things like that. I also think there's this piece about the more focus there is on everyone centralizing just using this service, a one-stop sort of crisis shop idea, is that we're treating crisis as if it is something that is individualized, medicalized, and it's not an opportunity to connect with your community, to build systems of support, or to learn how to navigate crisis yourself. So this experience is being treated as something that you need a professional intervention for. And people are, I think it's moving toward people losing skills to struggle, or to like be with struggle, or to consider struggle as part of their life. And I know Rob has some similar things to talk about related to that. I don't know if that was here, but yeah, I think there's this this concern for me that like we are going to lose our ability to navigate challenges because we're treating them like they require a medical intervention.
Thanks, Justin. I particularly appreciate you bringing up self-injury, because when I was doing my call, sort of secret shopping to 988, the self-injury responses I was getting as a 40-something person were just like the responses I got decades ago when I was in my 20s that led to my own forced hospitalization. There was no difference. And I guess I wasn't surprised, but I was really disappointed, disappointed that it wasn't
Yeah.
better.
And the national policy that Vibrant is trying to implement across the lines requires them to do a kind of risk suicide assessment within several minutes, 5 minutes, I think, of the beginning of the call. And so that's what I hear all the time from people. It's like they just felt like they were kind of having this weird, awkward, not real conversation where they're kind of being put through a test of some kind of screening procedure. And in fact, they were. And that's the predominant complaint I'm hearing from people. So they don't really feel supported at all. Rather, they kind of feel screened and tested. And if they can get to an actual conversation, then they'll appreciate it more.
For me, I have hated talking to 988 because even when I was at my lowest of lows 2 Augusts ago, August 26th of 2022, I was not having suicidal thoughts, but I was grieving my father when he was suddenly on life support. And I had a feeling that he was going to die soon. And the first thing I did when I called 988 is because none of my friends were available to chat. So I called 988 and the first thing I asked them is like, I need grief support groups right now. Like, can you please show me? And they were good. They'd actually that crisis counselor was good in that they did give me at least one resource in Los Angeles. And then after that, then they asked me, is there anything I can do for you in this moment of, of distress for you? And I said, well, have you been in my shoes? And he says, I'm sorry, I'm not able to disclose that. So I don't appreciate the clinical model in the 988 system, because I feel like the peer support system is when you share from experience and you show yourself to be a human and say, I've been there and you're not alone. I feel like that's an important message to be giving callers, when you can share that empathy and compassion instead of invalidating the person, which is how the July 29th caller Mark was acting. Like, oh, like I was talking about Van Gogh and like, how sad his life was as an artist, and no one recognized his talents until after he died. I'm like, oh, I definitely don't want to be an Asian I want to be an Asian Van Gogh that does not die by suicide, so, but yeah, there's so
Thanks,
much
Emily.
room
And
for
I was struck by also another call you had that I've seen the texts for, where you called in or you texted in and you asked someone for help finding support groups in Asian languages. And they basically said, nope, we don't have that. And while you're still asking questions, they basically hung up on or disconnected the call. That was really striking to see. Thank you for
so
sharing that.
yeah, that was so disappointing. That's the one you added in the article that you wrote. And um and it was just like, what? Like, the people turn to me for resources. I also look for, support groups for youth 17 and younger, because technically with NAMI, I was only able to help do support groups for 18 and over. And it's like, where are the resources for all the youth? Right? And it makes me feel like, where were all the resources when I was like that I could have taken advantage of before? But it seems to be very lacking nationally.
Absolutely. We're going to move on to the next question. So we've talked some about data, again, around police and use of force, but can we talk about what data they're collecting, what they are collecting, what we do and don't know about that? Jess, I'm guessing you probably have something to say about that.
Oh, sorry, it wasn't letting me unmute for a second. So I think the way data is collected is really, really variable. Different states are requiring people to, like, organizations to collect different data. The amount of data that's going to be collected is going to depend on the call taker in a really significant way, and then also what a caller is willing, or a texter is willing to provide. And so that's I think it's very complicated. Oftentimes we have some information about like the demographics of people who are calling. We don't know very much about, like, we have categories for why people are calling, but those are determined, the categories for why people are calling are determined by the individual agency. And depending on how they set up their system, you might be forced to select an option. You might be forced to select an option from only the options that they give you. And they might be really limited and might not cover actually what most people are calling about. You might be in a position where you can only select 2 different presenting issues. So the data itself, the way it's collected, is not very well monitored. And it's really not created by people who have a good understanding of data collection for the most part. So often it's deeply flawed, and it's presented as if it is data that they have really clear guidelines for. But oftentimes call takers aren't even trained in how to collect the data effectively and what the intent of the data is. So they're clicking buttons to get through a system to use people or to move people through. And so one of the things that happens is as a call taker, you can see like these calls in the queue. You might have 34 people waiting to talk to you, and you might move through that data collection really quickly and just select your own things just to get someone through the system, because there's all these people waiting for support, and that someone's likely to yell at you if they've been waiting for a long time for support, or that someone is going to be someone could die if you aren't picking up the next call. So there's a ton of pressure on the call taker that doesn't really result in good data collection or good service provision, that I think is really complicated. The newer you are, the harder it is to use these systems. The less informed about data you are, the harder it is to collect the information. And everyone is looking at this system and saying, you need to tell us what is happening. You need to give us good information. You need to give us good data about callers and who's calling and why and all this stuff. And there's pressure on the system to protect people's information. Not collecting it is the only way to actually do that. And so I think there's this position that's created where it's pretty difficult for the service providers. It's difficult for the callers. No one wants to be giving that kind of information when they're calling in for support. And if we don't collect data, there's no accountability for the system. And so like that combination is really complicated. There's also a lot of pressure on the call taker, or incentive on the call taker to report data that makes it look like they're doing their job well because they are supervised. And so if you are told that you're not, like, we have to keep a certain percentage of like active rescues, you're not supposed to send cops more than this amount, they might not say that they do, or they might say that something was not coercive when it was. They might interpret their actions as not coercive when they are coercive. So that call takers, the way that a call taker influences data is really significant. And there's not really any accounting for that within these systems, besides the fact that everybody is using a different system to collect the information, which I'm actually in support of. I think a universal system is really, really scary for a lot of reasons, because the oversight on this has been really minimal, and there are not good data practices, and they don't align with some of the best practices in the field of sort of data privacy and security. So I'm not advocating for a universal platform where all of this is collected in the same way, but we don't actually know what any of the data means.
Thanks, Jess. Yeah, and I remember actually being at that CrisisCon conference and asking a Vibrant person, how do you account for the fact that people calling in are likely to lie at times for various reasons? They just didn't answer me. So yeah, there's a lot of questions there. So I do want to jump to the next question, unless Rob or Emily, you have something burning to offer on this one.
I wanted to add that,
Okay.
This whole thing's been promoted on the basis of we save lives, and there's really no data to say that. So, I agree with Jess in a way, like, do we even really need this kind of data, right? Like, if you're just providing a support service of some kind, right, is that needed? Well, it's becoming needed because people want to justify these ungodly amounts of money that are being thrown into 988. And I do think, they need something to show that they're in fact saving lives. And so I say, if we're going to collect data points, it should be opt-in. If we've involuntarily intervened on you, there should be a standardized way for you to opt into giving them feedback so we can get some data from what's happening to that group of people in particular.
Thanks, Rob. And you actually provided kind of a lead into the next question. I'm going to keep you on the spotlight because I think maybe you'll have something to say here. So there's a growing number of stories and information circulating. Not that 988 hasn't done anything good, because we do hear good things. We hear about good calls, but that there's a lot of problems, right? That's what we're hearing today. There's a lot of problems, but people seem pretty resistant to listening to that. You mentioned lots of money has been invested. I'm curious what your thoughts are on why people are not wanting to hear this.
Yeah, I have to hold, all my quote unquote colleagues in the news media responsible, because I think most people would care if they knew what was happening, if they knew how often it happened, if they really knew what an involuntary intervention looked like, how people were experiencing that. I think people would care, and it's being sort of hidden. And I know now directly because of as a result of the book and other things that I've done on social media since that time, and other efforts from people, on social media who are trying to flag this issue. I've now been contacted by some of the major media outlets in the country and interviewed, and I know that they aren't actually then using that. They aren't writing about that. They are not highlighting these concerns. They write about 988, and they, at worst, they'll say, oh, a lot of calls, aren't making it through on time, or people maybe feel a little frustrated. They don't get enough time with the counselor. Okay, that stuff's true and important, but this is really important, and they're just consistently not really reporting on it. And to me, that's the heart of it. So we definitely need more public awareness of really this aspect of it, the kind of dark and sinister side. Because yeah, I don't think people do have a lot of problem with, okay, that particular counselor wasn't particularly nice that day. Nobody's going to get up in arms about that. It's like, okay, what can we do to help them, feel better when they're answering your call and have more flexibility? But part of the reason that's happened, as we've all highlighted, is because they're doing suicide risk assessments all the time, and it's just narrowing the way they relate and limiting the length of calls and all that stuff. So anyway, that's why I think there's just not enough public awareness overall.
Thanks, Rob. Do you, Jess or Emily, have anything to say on that?
Emily, do you want to go
Yeah.
ahead and go first?
Yeah, okay, sure, thanks. Yeah, because I filed a complaint with Vibrant Emotional Health because I went onto the 988 website, I submitted my complaint, they got back to me in a few days, and then I told them, actually, like, as a person who is not always good with email, I'm better at phone, but then, like, I'm a better verbal communicator versus with email. Sometimes I'm faster with text and social media. Everybody communicates in different ways, and so for me, it's like when I told Vibrant that I wanted to file a complaint and tell them what my story was, instead of emailing the whole complete story of how harmful 988 was to me that night, I asked them to call me, so they called me, and then I did tell them that, I'm getting these bills. Are you able to help me with that? And they're like, oh no, we're not able to. And like, and then like, I even asked like, oh, can I, get, they did apologize over the phone verbally, but I even tried to ask them, could I get that in writing so that I could show to the people who were sending me the bills? And they said, and I even requested the recording of my phone call to 988, and they said, we're sorry, if we're going to give you any information from us, you have to file a subpoena, right, or get a court order. And I'm just like, what? Like, do you not want to learn from your mistakes? Like, you want me to file a lawsuit against you? So that's where I'm stuck with Vibrant, and I don't know, so many problems in what I experienced that night. I'm like, I facilitated my own support group in the psychiatric ward, and the other Asian girl in the ward with me, she's like, you're the funnest person in here. I'm like, yeah.
Thanks, Emily. I appreciate you sharing.
I think
Jess?
like from the provider perspective, I think this is important too, is like, so there's why doesn't the public care? And then there's also like, why don't the people providing this service care? Because I don't think that there is, I don't think that the crisis service providers have responded appropriately to critique. They've personalized it. They are really defensive. They question the credibility of the people who are offering the critique. They're nitpicking misunderstandings. They're obfuscating facts, highlighting the positives, being like, oh, look at all this great stuff we do instead. And so like, this is all really classic stuff that we do to avoid critique. So at the same time as they're saying, please give us feedback, they're like, but actually not that feedback. And there's not room for them to take any accountability. And it's like, what that would look like is actually looking at strategies to address the behavior that's been identified as harmful. So like, if people are telling you that involuntary interventions are harmful, which, like, spoiler, they have been for years and years and years and years, why aren't we doing something about that? Why did we just carry this service over? Like, we would look at, the field would look at committing to ongoing development to transform the political conditions that reinforce this violence. So they would be looking at the laws and changing the laws about it. They will be providing safety and support from community members that have been targeted by harmful practices. They would be doing things that respect people's body, minds, autonomy, and self-determination. But we're not seeing any of that happen. And just like my thinking about that stuff, I feel like I need to give some credit here, is really coming from the work of like Miriam Kaba and the Audre Lorde Project and the Project Insight. Like, thinking about what it means to hold accountability in these processes comes from them. They have really great work out there that you should totally reference if you're looking at doing accountability work and not just me. But those things really should be happening. And instead the response is like pushing back and then looking at the people who have like been victimized by this system and trying to discredit them, which is like, this mental health systems are really based on this idea that if you are a person who needs help, you're like, so there's something wrong with you, you're not sane, and so you need someone else to intervene. So that's built into this system, and we see it happening when people are trying to hold the system accountable.
Thanks, Jess. You're reminding me that someone in the questions in the forum that we've been circulating during this event asked, why, if these suicide prevention approaches and assessment approaches have not been demonstrated to be useful, are we still using them? And it's part of the same question, the same conversation. It's such a big question and needs so much more conversation and digging in. All right, so last question before we go to the questions that people have been submitting. So this webinar was titled 988, Is It Helping More Than Hurting? I'm curious if you each can just quickly say, like, how would you answer that? Is it helping more than hurting? Who wants to jump in first?
My guess would be that lots of people who are calling for other reasons than feelings of sort of suicidal despair, that they're getting something of value from the service. That's what I would guess. So I really think it's that other group, the people who are seriously having troubles. I think they're probably being the most harmed. And I think that's where the balance is probably way out of whack. I think probably way more harm than good to that group of people. That would be my guess, but yeah, we don't really know.
Thanks, Rob. Emily or Jess?
I mean, I think it's doing both. And like, when we think about, is it meeting its own goals of being helpful? I don't think it's actually doing the things that it purports to do. No, I don't think it was really designed to do that very effectively at all. Do I think that people find some benefit from it? Probably yes, some folks do. Is it like the thing that I would design to meet like sort of the need that I see around like these experiences of distress and despair? Absolutely not. I don't think it is helping in that way. So it depends on how we think about that question. And like anything that really comes through the government like this, it often gets like, so it gets picked apart so much that the final service that we provide doesn't look anything like what we said we wanted to do to begin with. So that's my perspective.
Thanks, Jess. Emily?
I think that it's been harmful. I mean, neutral to harmful. I mean, sometimes helpful, but it's just, they act from the times that I've called, I feel like they come in with an attitude of, oh, we're supposed to know everything, and I don't even like their social media either, like all the whoever creates their social media posts and like, oh, you matter and blah blah blah. And just like, well, when you actually call in, do they even say that sappy stuff? It's just like, why aren't they even saying that sappy stuff when, and or even try doing breathing exercise. Would you like to try a breathing exercise with me, or put on like one of those meditation music, because music is like medicine, and healing. And so it's just, I feel like, yeah, they rolled out 988 too quickly. And I mean, it's just, it almost feels like it's just a show. Why are you putting on this bad show then? Like, and where people are not getting the support they need. And like my life coach, he said that the ER doctor in Hawaii, his friend, most of the time when people call national suicide hotlines, it's not to, it's because they're just looking for a friendly voice to talk to, and not because they actually really want to kill themselves, because if they really wanted to kill themselves, they would have already done it.
Thanks, Emily. Yeah, so I guess the one thing I'll add to that question to myself is that there's a trauma-informed, trauma-sensitive quality of kind of having a sense of what you can expect when you call somewhere. And when you call 988, I think one of the biggest problems is you have no idea what you're going to get. You might get the police. You might get a helpful conversation from someone who gets what you just said, Emily, or you might get something, in between that's not helpful, but not as harmful as the cops showing up, and you just don't know. And for me, that's honestly what it feels so unsettling. As someone who's called 988 and had the cops show up, there's just no sign of what to expect. And in my instance, it was almost 2 hours after I called that the police showed up at my house with absolutely no sign or warning that that was going to happen. So that unknowing is really, I don't know what to do with that. And I think that's one of the things we really need to look at with this. So I want to move on to the questions that people have been asking, and there are a lot of them. I now can guarantee you that we will need to do that follow-up recorded session, but we do have about a half hour here left to look at what was being offered. And there was, when I was looking through the questions that were showing up in the form, a lot of questions were coming up of like, how do I get more information? And I know, Jess, you were in the chat earlier, maybe some of that was offered, but I don't know if any of you can offer out loud. Where can people go to look for the 988 history? And is there a place where people can go in their own states to find out what the requirements are for staff who are getting hired there, or even a collective place that people can go to look at what the requirements are for all the states? Do any of you have thoughts on? I see you shaking your head no. Do you want to say anything out loud, Jess?
Yeah. There's not like a collective space to find any of this information. So like there might be there are some places that are sort of repositories for some of these things. But like really so in your state, probably the contract or like the RFP, like the request for proposals for your call centers would tell you some information about what the requirements for training are going to look like. You can contact some of the government offices involved, but depending on what state you're in, it might be a different government office. There might be an office of behavioral health or suicide prevention. It might be in your public health department. There's all different places where you see these kinds of spaces looking, or these kinds of this kind of information coming up. There are some national requirements for training. So if we want to talk, I don't know, Sarah, if this is the time for me to talk about what the requirements for training are. Yes?
Yeah,
Okay.
I think that makes sense.
Okay, great. Just wanted to make sure I didn't launch into something I wasn't supposed to do yet. The Lifeline requires, so like the 988 oversight from Vibrant requires some specific courses. There's 4 of them. It takes about 8 hours. So there's 8 hours of required training that everyone would have. And then there's some simulation training that could potentially take longer. Your individual state is going to require different training based on who the service provider is, what the state contract looks like, things like that. So it can look really different outside of this specific training. So the first course is about the fundamentals of crisis counseling. It's going to tell you what crisis counseling is, core competencies of effective crisis counselors, how their motivations and beliefs impact crisis counseling, why self-care and stress management are essential for crisis counselors. Then there's an essential skills training. That's another 2 hours. It's about why you should connect with someone and actively engage people in crisis, how to actively listen, how to ask clarifying questions, how to collaboratively develop a plan. So this is very, very basic kind of training. Um, and then there's going to be assessing safety and suicide risk. And this is like, why do attitudes and feelings about suicide impact crisis interventions, or how they impact it, how to ask about suicide, how to assess safety using a Lifeline specific model. I could talk more about that model if that's helpful at some point, but it gets really nerdy and maybe not relevant to everyone. And then how to develop a safety plan. One thing I would note is that the model for a safety plan that was developed, that the Lifeline uses, was originally developed for people exiting hospitalization, and you're supposed to spend an hour doing it, and that is not the length of time that most calls last. So they're not even doing that safety planning to fidelity based on like the evidence-based practice they're referencing. That's complicated. And then imminent risk of suicide, which is like a 2-hour training. It's going to talk about what imminent risk is, and responding according to the Lifeline suicide safety policy. Each state also defines this stuff on their own, so it could look different even than what the policy is saying. Recognizing the most effective ways of supporting individuals who are at risk, and determining whether emergency intervention is warranted, and taking steps when it's necessary. So this is the kind of training that everyone is required to have. And then your state is going to require different trainings. I did a survey of organizations that were providing this service before 988 launched, and people were giving their volunteers or paid staff anywhere between 12 hours and 160 hours of training, depending on the center. And then the requirement before that about like if you had to have a degree, if you had to have like living experience, things like that, those requirements were all over the place. So when you actually get to a counselor, this 8 hours that we just talked about is the only thing you can really reliably expect that people would have training about. And none of this teaches you as a crisis provider how to sit with your own fear about working with someone who could potentially die, which is the thing that I think is the most important skill, is that you have to be able to sit with someone in the pain that they're experiencing. You have to be able to tolerate as much distress as you're asking them to. And none of this gets at that, not at all. And that's the thing that makes people make bad decisions, is their own fear. So we're not teaching people the things that they need to know to do this work.
Thanks, Jess. And someone asked while you were talking in the chat about whether or not these training requirements were introduced right at the start of 988 or if they've been coming afterward.
So most of these training requirements looked similar already before 988 was even introduced. They were like similar Lifeline trainings. More stuff has been developed over time. And there's a lot more that's probably going to be rolled out. There's definitely funding for more training and things to be developed. It's really getting pulled in a lot of different directions though, because every group of people who experiences crisis wants themselves represented in this system, right? And they should. And so that's how this training how trainings really balloon into something that's really big and not always particularly useful. So and I'm like this is what I do, is like develop training. So I feel really personally attached to this stuff. And I think that we're missing the point a lot, because a lot of what we're actually doing is trying to train people to follow policies, and we're training people to follow the Lifeline policy, the 988 policies, and your internal organizational ones, and whatever the state decided policies should look like, which is going to look different everywhere. So we get caught up in that instead of the things that actually help people support people in crisis.
Thanks, Jess. And I see people in the chat also appreciating what you said about needing to learn to sit with things rather than do something to someone else. So thank you for naming that.
Sorry, Sarah, interrupting. I'm just so like, I want to affirm what Jess was saying too, that yeah, that's just it. Like that's the training that people need. And it's important to highlight there that even the most extensively trained specialist of mental health, there's no evidence that doing that helps them assess risk any better than an average volunteer with no training. So that's the thing we're trying to target, is like, let's get the accuracy of suicide risk assessment better. We don't have that methodology. There's no study, there's no research that shows we can make experts good at that. So why are we going in that direction, right? Really, we should go in the direction that you and Jess are highlighting and others are highlighting, is that people need training and yeah, being with pain and being able to allow that kind of stuff to be expressed and shared.
I think like even just one like additional thing is like even if you are someone who has a master's degree, like a clinical licensure, there's not a guarantee that you've been trained about crisis or suicide at all. There's not a national requirement around that. And if you are trained in it, you might be trained in these systems or these kind of support strategies that are based on bad evidence that don't actually work. Like we don't know how to assess risk for suicide well. And that's what we teach people to do, if we even teach them to do that when they're getting a clinical degree. So like we don't actually have a pool of people to call on who know what to do in crisis, who are clinical workers.
Thanks, Jess. So,
Uh,
oh, sorry.
Can-
This,
So I have this book called Basics of California Law for LMFTs, LPCCs, and LCSWs. I'm borrowing this. And it's because like I would think that it would be illegal to falsify patient information in their patients' records. And I'm just like, I don't care about the letters behind a person's name, because Martin Luther King Jr., he says, I dream of the day when my 4 children will not be judged by the color of their skin, but by the content of their character. So regardless of whether people are getting these letters behind their name and spending so much money on education, like, what's the point of it if you are actually harming your patients by falsifying information in their patients' records? Like my issue with my 5150 is that one of them was that they did not properly assess me for suicide risk. Yes, I had suicidal thoughts, but the ER social worker, she answered all the other questions of suicidality assessment. And then she writes in the paragraph right after, patient reports that she does not want to harm herself or others at this time. I'm like, wait, what? How can you report an oxymoron in my patient's records saying that, yes, I have a suicide plan, a detailed one, and this is in the beginning of my 5150. So it's just, I would hope that even when people get trained, that you really know what you're doing and not just, you have to figure out what is a safe space. How do you create a safe space? And I think that part of that is also learning how to create that safe space for yourself, of accepting a person and not invalidating a person, and like using toxic positivity. And yeah, so
thanks, Emily. When you say that toxic positivity, I was kind of thinking that earlier when you were saying, like, why don't they use the slogans from the billboards? And I'm like, oh, I don't know that that would go well for me either. but thank you. So we had an interesting question in the submitted on the forum about the use of artificial intelligence. And I'm curious if any of you know anything about that. Is that beginning to show up here? So I've heard it in a couple of different ways. One is, are they going to start to use artificial intelligence to fine-tune assessments? But also there was someone, I think, who was actually asking in the forum about whether or not they ever use artificial intelligence to actually respond to people, for example, in the text. Do any of you have any information about that?
I don't know about whether they're using them to actually do response. So maybe Jess knows about that, but I can say that I discovered that a number of lines in Canada definitely are using the AI to analyze conversations. So all these conversations are being transcribed, and the text ones, are already transcribed, obviously, and they're using AI to analyze that and actually flag for interventions. So presumably, you hope they told me in the end, although their policy did not say this, but when I publicized it, they said, these are still reviewed by a human before we contact police. But in any case, it's the AI that's actually doing the first flagging if a human hasn't done it yet. And then AI is being used in connection to all sorts of research, and that came out with Crisis Text Line in the US. So we don't know. 988 is so much is hidden here that we don't know what they're doing. Like, do they record conversations? Jess, do you know? Maybe you could answer that for me, because I see no discussion of it on their website, like yay or nay. And I'm like, what, is there a policy? There should be a policy. In Canada, they established policy. Yeah, we do. So at least it's transparent. But yeah, anyway, that's my little comment on AI.
Thanks,
Wow.
Rob. Jess?
Yeah, so like 988, like the big broader organization of 988, that's not sort of part of the service at this point. I do know that so Meta has which is like Facebook and Instagram. Sometimes people don't know who Meta is. Meta has been working on projects where they use so they use artificial intelligence to look at like language that gets used, like terms that get used close together. And if these terms are used at this frequency or whatever inside a conversation, that person might be more likely to die by suicide. There are a number of organizations that have been looking at this data, social media data specifically, and death data to see what those kinds of terms and stuff are. So there's definitely movement in that space in the industry. Like, people are looking at this. The implementation side of it could look anything like what Rob was talking about, where if you're in the text and chat platform, something's going to pop up and say, like, hey, you should do this risk assessment. You should do this intervention. So that's the kind of stuff that actually I think we're probably nearer to as far as individual organizations are concerned. But the capacity for 988 broad scale to do that, like to actually use those systems, is probably way off in the future. There's not really the funding to support that. And there are lots of chatbots that are used by like HR software, things like that do this already. So like, if you are using your health insurance platform, it's probably talking to a computer there. There is also some research that when people got services from AI versus from a actual trained counselor, they preferred the AI intervention. So complicated there. I'm not really sure what we do with that information. I think that AI is probably equally as dangerous as individuals who can restrict your freedoms. And so I don't know that it's worse or better, but it's definitely there. It's present in the fields, and there's movement toward it. So it exists, and different organizations have tried it. I know that there are text and chat platforms, big ones that have tried to use this, had piloted some programming around it as a support tool for crisis counselors. But yeah, I don't think we're anywhere near 988 wholesale using AI in that way. But I think there's lots for us to be worried about that. Especially since the development of all of this stuff has really, it has been developed based on data that you have either agreed to share because you wanted to participate in using a platform, for example, or data that's maybe been illegally acquired from you, or previously it wasn't illegal, but it is now. And so this data privacy field is really evolving, and the crisis industry is way behind on keeping up with what they should be doing based on actual data privacy regulations, because they really look at things like HIPAA and not at data privacy laws that are a lot more connected to this kind of side of this stuff. So I think it's complicated. It definitely exists, and it's not what's being used predominantly at the moment here.
Thanks, Jess. All right, so there was another question about whether or not there's any evidence that the system has been used or could be used to get someone else picked up by the police. So for example, like there's lots of moments in our history where people had power. Think of Elizabeth Packard's husbands so many years ago, having her committed because she wanted to raise her children and differently than he thought and had a different religion than he had. All the reasons that people have in the history of the psychiatric facilities and all that. So has there been any evidence that that is happening with 988, or is there any protection in place to keep that from happening if someone were to try and do that?
No, there's no protection. And yeah, absolutely. It's already, we know we've got lots of examples of that through 911 that it happens, and there's no reason it wouldn't happen with 988 as well. We see that there's a certain percentage of calls that are from third parties supposedly concerned about someone else, and the policy states that that can be a trigger for an emergency intervention. So it's just a matter of how you come off, how credible you are to whoever's answering that, and how easy they see it as the intervention to occur. So I think the risk is real, and that's embedded problematically. It's really, in a sense, not a 988 issue per se. It's a 911 issue, and that's really an involuntary intervention issue that anybody, has the capacity to call in emergency services on anyone else relatively easily across the countries. And that's a real concern. And that those laws are in place. Mental health laws allow that kind of intervention to be very aggressive. If it was simply that the police would come and talk to you, and that's all, the way they might with an accused criminal, and kind of go, well, what's really going on? That would be okay, or at least less dangerous. But the fact that they can come and literally just decide to take you away in handcuffs and put you in a hospital against your will, that's a pretty powerful tool to be just distributing to anyone, to be able to do to anyone else.
Thanks, Rob. All
I think
right.
it's oops, sorry.
No, go ahead.
Okay. I think that this gets into a really complicated space. So this group of folks who call in are called concerned others. There are also third-party professionals who call in. So this is other people who work in systems who might call on someone's behalf. And I think a lot of folks who work online struggle with concerned others and knowing what to do. There are people who absolutely call with the intent of getting someone locked up. And looks like something similar to swatting. I think that some centers do a better job of training people to look for that than others. Some call takers are better at looking for that than others. Ideally, what they would be doing is referring people to other services and not just you should be talking to a person. Like if you're a worker doing this, you should talk directly to a person and do an assessment before you would ever send 911 there. If you want to cover your ass about the way that you're doing this work, you should be doing that. That doesn't mean that that's what you're being trained to do. That doesn't mean that's what 988 is saying to do. Like sending people based on an assessment that you didn't do with a person is a dangerous place. And if you have a license, you should be worried about that. You have to do an assessment on an actual person, not based on something a family member or friend or whatever says. So just as a provider, you should consider that if you are one. But it happens all the time, and the more dangerous it sounds, the more room there is for that kind of intervention to happen. And the big thing that I want to point to here is Tarasoff laws. So these are laws that are designed to, if you are threatening someone else, there are laws that protect mental health providers and other folks from contacting law enforcement, contacting whoever they think is the target, things like that. That is the space where you are most as concerned others most likely to be able to sort of weaponize a system against you, or even if they are doing it in a concerned way, for the system to act as a weapon because it is one. And so I think that's complicated. And it's sort of based on all of those laws are based on the idea that we can predict when people will engage in violent behavior or they're likely to, and that we should be intervening based on a prediction of violent behavior. There's a lot of movies and sci-fi that's about this stuff, right? I think there's a lot of directions that can go, and we treat these laws like they're really normal, and they're not. This is about predicting futures that we are not good at predicting, and taking away people's rights. So I think that's a space to really advocate around, is looking at what are the laws around Tarasoff and imminent risk in your in your state, and looking at ways that you can change those, because that will drive the system.
Thanks, Jess. While I have you in the spotlights, oh, you just turned. Sorry. While I have you in the spotlight, there was a question about address safety, and I saw you earlier in the chat saying things about how to keep your info safe. The person was specifically asking if someone's a domestic violence survivor and they have a safe, protected address, is there a way for these systems to still get them? So that's the question, but also just wondering if you can share some of what you were saying in chat earlier.
Yeah, so I mean, if someone has a safe protected address, that probably means they've done some of the steps to make that address less public. Where that can get really complicated is if, like, your community mental health center where you go and get your therapy services from has your actual address, and they are also the service that provides 988. If they don't have the right safeguards within their data system, they can look you up and send cops. And if it's your ex-partner who was abusing you, who is contacting, ideally they wouldn't give that person your information, because that there's not a lot of situations where that would be considered okay within this industry, but like, they can then send people, right? Like, that's a strategy that's used in domestic violence, is to make people look less sane, right? So if that's happening, someone can call about you, express a lot of concern, and get 911 sent to your home, if it exists within those systems already. Now, that's like actually a violation of your data privacy, like that is something that violates HIPAA. So shouldn't happen, but it absolutely does, because I can tell you the workers don't know that. And if they haven't put the guards up in the system to prevent people from accessing all the additional information, yeah, your address is probably in there. So that's within a private system. In the public sphere, that might look different. So you've probably done things to make sure that your address isn't public.
And some of those things you were mentioning in the chat were like you posted a particular website, right? That we can
Yeah,
include
I'll
in the
post the
resources
website
when we
again.
send them out.
Yeah.
Okay. Thank you. All right. For all of you, another question that was coming up was, is it fear of liability that is ultimately driving this hyper focus on suicide risk assessment? And what do we do with that if that's this driving fear? Anyone want to jump into that?
So the answer I got to that from Susan Steffen, who's an attorney who's written an entire book about suicide laws and looked at calls lines, is that it's very rare for any suicide line to be successfully sued, because judges don't tend to see it. The law doesn't tend to see it as like a doctor-patient relationship or something like that. Unfortunately, these lawsuits happen, right? Upset families or whoever may sue, and it sort of can create a certain kind of fear, but it's rare, relatively rare, it seems, to be successful. What Bart Andrews said to me, one of the people that worked on the National Suicide Prevention Lifeline, was he talked about this feeling of moral liability. So he said a lot of people who answer the calls will feel a sense of liability, a sort of responsibility to the caller, a certain kind of paternalistic level of that, as Jess was talking about earlier. And I think that's probably really a bigger factor in this. It's not the hardness of the laws, but it's more people who take up that role are often thinking, oh, I should do something here, and I'll feel really bad if they die, so I'm going to do something.
Thanks. In our alternatives to suicide trainings, we call it emotional liability, but it's the same idea. It's like people don't want other people looking at you saying, oh, could you have done something differently? And they don't want to look at themselves and say, like, could I have done something differently? And all that is a huge driving factor, but it's way easier to say it's the legal liability. It's all about the legal liability. Jess or Emily, you want to add anything?
Yeah, I wanted to say that, some comments in these ever since my 5150 that I've received are things like, oh, I'm glad that you were 5150. I'm like, wait, what? You're glad that experience happened to me? And then like another response I've gotten is like, like the mayor of my city, she's like, oh, well, the first responders were trying to be helpful. do you understand the treatment I received in the freaking ER? And it's like, because the thing with 988 is like, when you are a kid, we've been taught, like, if you've been taught the game of telephone, if the first person misunderstands you, then the rest of the first responders will also misunderstand you too. But by law, they're legally able to use 988's crisis counselor as a viable, or a person, like, because the fire chief told me that they are allowed to put me in the hospital without my consent, based on hearsay. And I'm like, wow, that is a terrible thing to do, because it's like you could pull a prank on anyone and make them pay for it after that trauma. I'm like, that's a terrible prank to pull on someone. And so that is a loophole in the system that just really needs to be fixed.
Thanks, Emily. All right, we are really almost at the end here, and I wanted to offer just each of you a chance to say kind of a closing thought. And if you're able to, there was this one question that came in about, like, are there particular ways we should be advocating, particular laws we should be advocating for, or changes in policy we should be advocating for to encourage more transparency? If you're able to work that in to any final thought you have, that would be great. I just wanted to put it out there, and just a reminder to everyone else, we will be coming back with a recorded session to follow up on other questions that we're not getting to. Who wants to jump in first?
I'll go quickly first, just like, I just think we should get rid of call tracing of all kinds altogether without consent, and there are already great, like, successful lines. I think Wildflower Alliance runs one that do not trace calls. Samaritans in New York City, there's lots of them. I wish we knew them all. We need a directory of all the ones that don't under any circumstances trace calls against people's will. So that'd be my roundup, is let's start a movement to just get it out all together. I think, like, you can clearly, if you're looking for help, you can still do that. You can contact 911 directly. They'll show up. You can say to them, here's my address, please come help me. That's still available.
Thanks, Rob. Emily or Jess?
I think, like, to me, the things that I would want people to consider are, like, how do we move toward abolishing non-consensual police contact in crisis? Like, how do we move around these laws? So any laws related to mandatory reporting, imminent risk, grave disability, those, and then terrorist off laws are the ones that we want to look at that are going to involve non-consensual interventions. And then, like, from a policy perspective, I think looking at ways that we can move our orientation around crisis toward things like harm reduction, that allow people to make more decisions, and then really lifting up peer support and other marginalized voices in this process of, like, developing policy would be really helpful. And I think to do that, we need a lot of cross movement solidarity that I don't see happening among sort of disabled people working around racial justice, things like that. I think that those of us who want to see these changes happen and want to see the sort of carceral logics underpinning these systems shift, really, really need to collaborate together to make those things happen, so that we make sure that people are actually protected in systems that are supposed to provide care.
Thank you so much. I love the cross movement work. It's so important. Emily?
I think for me, it's figure out what works well in your toolbox. And when you feel like you're in emotional distress, call your friends that you trust the most. And if they're not reachable, then try calling your other friends. Because I mean, I would never, I have vowed never to call 988 ever again, based on my own experience. And as much as I understand that the government is trying to be helpful. The way they're going about it, it's not helpful. And I think what's really important is to just get to know your own community, your own local community, and because you become who you hang out with. And it's so important to be around people who do know you, understand you. Join those support groups that Sarah talked about. I hope we have a psychiatric survivors support group one of these days. And I'm also gonna get LA County Department of Health has given me a space to be able to chair a future mental health awareness event. I don't know how many people, but here in Southern California, Los Angeles, for the San Gabriel Valley. And I'm planning on getting presentations from LA County Department of Health Emergency Services Bureau, their psychiatric service, PMRT, mental health mobile crisis teams, and any police departments who have their own mental health evaluation unit. So I want transparency just as much as you guys do. And it's like, who's ever seen a presentation on this is what happens in a psychiatric detention? And so if anyone can provide that kind of presentation for us, oh, I would love to hear it.
Thanks, Emily. Yeah, and I just want to recognize, so when people have their own networks, that's so powerful. And then, I'll call myself out as someone who has a really hard time developing a network and having places I feel like I can reach out to, or friends I've been able to maintain connections with. And so I appreciate this movement in a part of Australia that I learned about at some point. I think there was a group specifically for people who identified as quote unquote misfits or something, like how do we create community for people who have trouble finding those connections or don't have the privilege of family and things like that. So there's so much work for us to do. I really appreciate so much of what's been offered here today. I know we're leaving tons of questions that we're going to need to come back to, but thank you all for being present and invested in change and doing this work together. So we're going to turn off the recording and close and say goodbye.